Thank you for tuning in to another edition of The Heart of West Virginia. I'm your host, Hoppy Kercheval. And today, we're going to talk about aneurysms with Dr. James Mehaffey, WVU Medicine cardiac surgeon and co-director of research in the Division of Cardiac Surgery. Doctor, welcome.
Thank you. Thanks for having me.
Thank you for being here. So most people would know that an aneurysm is a bulge or a ballooning in the wall of a vessel, but give me a little bit more of a clinical explanation that you might provide to a patient when you're talking to them about what an aneurysm is.
Yeah, certainly. Aneurysm, just kind of as you outlined, is a dilation of a blood vessel. And the blood vessels that we predominantly talk about and work on in the cardiac surgery realm are the aorta, specifically the ascending aorta,
which is coming from
that
from
arises,
the heart?
Correct. I guess we'll start at the root.
Okay.
The root is where the aorta attaches to the heart.
Mm-hmm.
And then the next segment up would be the ascending aorta. And then that connects up to the aortic arch, which gives the branches that go up to the brain and the arms.
Mm-hmm.
And so that's generally the realm of aneurysms for cardiac surgeons. We manage dilated blood vessels in that entire area, as well as any tears or dissections in that area as well.
Mm-hmm. What causes these bulges?
Yeah, so excellent question. It's really what we refer to as multifactorial.
A lot of things can... Yeah.
Exactly. There's many things that contribute. Very rarely can we pinpoint one specific thing, but there's certainly a genetic component, and there are a number of inheritable aortopathies, defects in connective tissue that cause or predispose patients to develop aneurysms. And we typically see that throughout generations of families. And those patients will frequently have very aggressive aneurysms that can present early in life, even as teenagers and young 20s. But those patients are typically intervened upon much earlier in life, and those there are screening for patients who have known family history of aortic aneurysms. But the overwhelming majority of aneurysms are related to environmental exposures, high blood pressure, and idiopathic causes or things that we don't fully understand. But certainly when we identify patients with a root ascending or arch aneurysm, the initial management is frequently conservative or observation, surveillance, based on the size of the aneurysm. Because when we make a decision about when to intervene, when to do surgery for an aneurysm versus when to watch it, it's all based on the size of the aneurysm and the risk that you have a complication from that aneurysm. And the most likely complications of aneurysms are either rupture or aortic dissection, where the layers tear. And the challenge is, as that aorta grows and expands, the walls become thinner. And you can imagine there's a tipping point once you reach a certain size. And that's really the decision point around the management of aneurysms, is when does the risk of intervention or fixing the aneurysm lower than the risk that you have a complication from that aneurysm just by watching.
And I want to get deeper into that, but I want to go back because of something you said, that you wouldn't necessarily know that you have an aneurysm. Most of us think aneurysm is the actual event, but the aneurysm is the bulging that takes place. So most of us wouldn't know, but if you're thinking about your health and if you're thinking, well, Dad had an aneurysm and it killed him, or he became very sick, or Mom, wouldn't that be a warning sign that you should somehow be checked out? And how can you be checked out?
Yeah, no, excellent question. So certainly patients who have a family history of aneurysm disease, getting imaging is the way we look and surveil for aneurysms. That can include CT scan of the chest, typically with contrast to help us see the outline of the aneurysm, or an ultrasound of the heart, and that particularly where the aorta attaches. So for those root and ascending aneurysms, that helps us see those. But back to what you were saying about aneurysms being asymptomatic or not having symptom. That's a very common question I get is, patients want to know, well, how will I know if this thing is growing? Or vice versa, I have chest pain. Could this be my aneurysm?
Mm-hmm.
And the answer is typically, as you pointed out, there are no symptoms. Now, very, very, very large aneurysms, if they're growing rapidly, there can be pressure and some sensation associated with those. But the overwhelming majority of aneurysms are completely asymptomatic until they cause a problem, that rupture or dissection.
That's pretty frightening, because if it's asymptomatic,
right,
what is a person to do? What do you? Just that.
Yeah, no, absolutely. And I think that's why it's important to identify these and then to follow with regular screening. If you're found to have an aneurysm, to follow regular screening, monitor for any change, year over year growth.
So get a baseline and keep an eye on it.
Correct. Yeah, I think that's one of the exciting but challenging things about aneurysm surgery. The other thing is that's part of the conversation that we get to have with patients when they're diagnosed with an aneurysm, because obviously part of that is balancing, knowing that I have this aneurysm inside of me. Why would I not just get it fixed now? And that really comes into, as I was mentioning, about those risk versus benefit and the balancing those scales, the risk that something happens with that aneurysm, a rupture or a dissection, versus your risk to have it electively fixed, because open heart surgery, it's a big deal.
Yeah.
There are risks associated with that as well.
So let's go there. So you identify an aneurysm, an individual, and I guess a lot depends on size and location. So let's say it's a smaller aneurysm. I think it's below 5 centimeters. Is that right?
Yeah, it depends on exactly where it is in the patient, but yes, generally below 5 is aneurysms that we would observe.
Okay, so you let's put a face on this. You patient has an aneurysm and it's below 5 centimeters, and you talk to them and you say what?
Yeah. So again, I would take it back even one step, and we have to put it in the framework of, well, your aneurysm is 4.8 centimeters.
Okay.
What size is it supposed to be? Are you a 6'6" man with, very large organs and everything else? And, yes, 4.8 is still an aneurysm. Yes, that's still a little too big. But that's very different than if you are, a 4'11" female with, the remainder of your aorta is very small, and this is a very focal dilation. That 4.8 becomes a much higher risk for you, because that's significantly out of proportion. So we do index these aneurysms based on the patient's height to try to help give us a sense of how outside of bounds these aneurysms are. And so really we personalize and individualize the treatment to each patient based on what their aneurysm characteristics are and what size their aorta should be.
So if it's if it's a circumstance where let's say it's a larger person and it's 4.8, then you have non-surgical treatments you can do, right? Which are what? Yeah.
So really the non-surgical, or I would really put this in the surveillance and medical treatment. And we typically follow those. After the first diagnosis, especially if it's 4.8, I would usually get a repeat imaging around 6 months. I would want to know a little bit shorter interval, but I want to know if this thing's rapidly growing, because it's 4.8 today, but if the patient's 55 years old, it could have been 4.8 for the last 45 years, or it could have been 4.8 for the last, it could have grown this much in the last 6 months. And so we really need to know kind of what the trajectory of that aneurysm is. And so generally the first, when it's first diagnosed, the first follow-up is about 6 months later. And then if it's stable, we pursue annual surveillance. And sometimes in patients, especially as they get more advanced in age, if they've demonstrated several years of stability, we can even stretch it out to every other year. Now, that's the surveillance part. The other medical treatment part, it's limited, but really the only thing we know of that prevents growth in these aneurysms particularly the multifactorial aneurysms, are good blood pressure control. So hypertension, the medical term for high blood pressure, is typically considered, we use a cutoff of a systolic, a top number of 140. For patients with aneurysm disease, we knock 10 points off that, and your goal to try to keep your blood pressure under 130.
Because if it's higher, it would put more pressure on the weak spot. Is that right?
Exert more wall force. And I always kind of talk to patients, it's not necessarily, you can never have your blood pressure above 130 or your aneurysm is going to rupture, but your resting blood pressure, in the morning when you check it, should be below 130, not necessarily after you've been out exercising, things like that.
So let's go to a more serious matter where the aneurysm is larger. There's a greater concern that it could rupture, and you're going to talk surgery options with the patient. Have that conversation.
Yeah, no, absolutely. So again, it goes back to exactly where the aneurysm is. So I'm going to take these in 3 different parts. Okay. First, we'll start with a root aneurysm. So that's an aneurysm in the aorta where it connects to the heart. And
would that be the most serious?
I wouldn't say that any of them is more serious than another. Okay. They all require open heart surgery, but the thresholds for operating and what needs to be done is different for each aneurysm.
So I'm sorry, go ahead.
No worries. So we'll start with the root aneurysm. So those are the ones where the aorta attaches to the heart. Now, the other part about where that aorta attaches to the heart is there's a valve that sits there, the aortic valve. And that valve opens and closes with each beat of the heart, plays a very important role in allowing the heart to relax, or during what we call diastole, the relaxation of the heart. That valve closes and allows the heart to passively fill with oxygenated blood that's coming from the left atrium. The challenge is, as that root aneurysm develops, it pulls the leaflets apart and causes that valve to start to leak. And when that valve starts to leak, that nice period in which the heart is relaxing during diastole, all of a sudden it's trying to drink out of a fire hydrant. It's got aortic pressure kind of flowing backwards, filling the ventricle, and that puts a lot of stress and strain on the heart. It can cause the left ventricle to become dilated. It can eventually cause very significant heart failure that can eventually kill the patient. And many patients with root aneurysms that are left untreated, that's their ultimate demise, is heart failure from a leaky heart valve. So when we're repairing root aneurysms, we have to replace all of the abnormal aorta around where that aorta attaches to the heart. Now, this is high rent real estate. There's a lot of other things, like the coronary arteries that plug into the aorta just above the aortic valve. And so typically replacing the aortic root requires rerouting or reinserting those coronaries, and then dealing with the valve. Sometimes the valve is too destroyed to save, and we have to replace the valve as well. Many times, and one of the things that we focus on here at WVU is saving heart valves and performing procedures like a valve-sparing root replacement, where we actually save the patient's valve, remove all the abnormal aorta, and then resuspend the valve inside of a graft, so that the patient gets to keep their normal functioning valve. We then reimplant the coronary arteries, and then that patient can go on to live a normal life just without their aortic aneurysm.
Very complicated surgery, correct?
Yeah,
and what is the risk level to the patient? I mean, it's better than sitting there waiting for a rupture, but there is a risk to the patient, correct? So anytime you're doing that kind of surgery near the heart, there would be a risk.
Yeah, so anytime we're doing open heart surgery, there are risks. Most of the risks of these procedures are more related to the patient's age and medical comorbidities than the procedure itself. So in a young, healthy patient, their risk for a valve-sparing root replacement could be as low as 1 to 1.5% risk of dying. However, someone with more advanced age, more medical comorbidities, yes, that can be much higher, 5, 10, even 20%. The other component of that valve, if we can't save the valve, if we can't do a valve-sparing root replacement, then we're left with 2 different options to replace the valve. We can either use a mechanical heart valve, which is made from carbon fiber, It lasts forever within the body, but requires the patient to take Coumadin, a blood thinner, every day for the rest of their life. Alternatively, we could use a tissue valve or a bioprosthetic heart valve, and those are made from the lining of either a pig or a cow's heart, bovine or porcine pericardium. Those valves have been around for many decades. They work very well. They do not require blood thinners, but they do wear out in the body, usually in about 10 to 15 years. And so these are all options that we have to deal with in root aneurysms if we can't save the valve. So that's kind of a little summary of root aneurysms.
Yeah, that's and then there's ascending and also arch. So what are the differences there, and how do you approach those?
Yeah, certainly. So unlike the root aneurysms, the ascending aneurysms are less likely to cause valve leakage. They still can cause that valve to become incompetent and have to be dealt with, but most of the time, ascending aneurysms, we actually only have to resect the aorta above the coronaries, so between the coronary arteries and the branches to the brain would really be considered the ascending aorta, and those ascending aortic aneurysms run very common with things like people who are born with bicuspid aortic valves, so 2 leaflets instead of 3, have a much higher predilection to develop these ascending aortic aneurysms. And but those are performed through open heart surgery. We still have to stop the heart, and then we just replace the segment of aorta that is diseased.
Certainly the worst case scenario is you see a patient rushed in here where there's been a rupture.
Yeah, certainly.
Then what?
Yeah, so rupture, or more commonly a dissection, which is what results in the rupture, that certainly changes the calculus a little bit. Those patients require emergent surgical intervention. And the goal of that surgical intervention is to remove the segment of aorta that is torn or ruptured, repair or replace the aortic valve, because that's typically affected by the dissection, ensure that the coronaries are widely opened and delivering good blood flow to the heart, making sure that the tear or the rupture in the aorta is repaired to the point where the blood flow to the brain and the rest of the body is not compromised. And those are really the basic tenets of operating on emergent ruptures or dissections for ascending aortic aneurysms.
How critical is time in that?
Yeah, certainly very important. Many times we get calls from outlying hospitals. It's frequently late at night, but those patients are emergently transferred frequently directly to the operating room, and we perform those operations immediately as soon as we can get them to an operating room.
If somebody has the breakage in the aorta, and then there's going to be no or minimal blood flow to the brain. So would there be lasting damage if you don't get to that quickly, even if you save the person's life?
Yeah, certainly. Strokes are a major concern with ruptures and dissections. Many patients present actually with strokes or with malperfusion, meaning inadequate blood flow to kidneys or legs or parts of the brain, and getting their surgery done as quickly as possible is the best thing that we can do to restore the blood flow. But even in patients who present without strokes, their risk of having a stroke during that heart surgery is significant, as high as probably 10 or 15%. And so these are all things that make repair of a type A dissection more challenging. Now, we say that, a patient's risk of dying from a type A dissection increases with every increasing hour from that it takes for them to get to an operating room. And but if we take all patients who receive an operation for a type A dissection nationally, the risk of dying is about 20%, and that's the patients who got surgery. There are patients who maybe prohibitive risk, may be too elderly to receive surgery, all those things. So that doesn't truly capture all of the mortality of a type A dissection, but it's a very serious issue.
Yeah. What drew you to this particular discipline?
Yeah. So by training, I'm an adult cardiac surgeon. I do the breadth of adult cardiac surgery, everything from valves and coronaries to aortic and heart failure. But I do particularly like aortic surgery because of the challenge, the acuity. I think it's many times it's a challenging plumbing question, right? It's in the most basic sense. It's getting blood delivered to an area, making sure that the conduit in which it flows through is adequate and doing the job. So I think that heart surgery in general is I'm a little biased, but it's the best field in medicine. The heart is a great organ, many challenges. It's like I said, a great field that can certainly keep you humble. But aortic surgery in particular, I think is very satisfying to take patients that have these severe problems, life-threatening problems, many times asymptomatic. Doctor, why do I need a big open heart surgery? Yeah. I don't feel, feel bad. And to be able to reduce or to totally cure and get rid of their risk of having complications from this.
How do you manage what I would think would be the stress associated with life-saving, life-altering surgery after you've had the conversation with the patient and family in a serious manner, saying, look, this is what it is. Let me be honest with you. This is what the risk is. Yeah. And now you're going to go to the procedure. That is their life is in your hands and your staff. How do you manage that?
I think the second part of that you said is really important because it's, yes, it's the entire team that's delivering care. Here at WVU, we truly have the best team in the world. I fully believe that. We take care of the most critically ill patients and most challenging issues, and we get them through that because of the whole team that we have. I think dealing with things and patients really appreciate. They want you to be honest. If things are bad, they want to know, but they don't need it beat in their face either. And I think at the end of the day, many times the patients just have to trust that you're going to make the right decision and do the absolute best you can for them. And we're very fortunate to have excellent patients and a lot of really good people that come and get their care here.
What is it like when, after a successful surgery in a serious matter, you go into that room and you see the patient and you see their family? What is that moment like?
Yeah, no, I think it's great. And honestly, I think when the patients when the families of the patients get to come and visit with their loved ones after surgery, kind of all that emotional release of, many of these patients have been waiting for surgery and they get the surgery, and then the family gets to come in and be there and see them kind of getting through the other side, I think is great. I think getting the patient through the hospital is an important part, but also even more rewarding to see them coming back, see them in clinic 30 days later when they're feeling better, got their hair done, and have their normal clothes on. But then even more rewarding because many of our aneurysm patients we follow up for years after surgery, and to see them coming back and be a year or 2 years or 5 years removed, valve still working great, doing well, living their life. I think that's the most rewarding and important part.
And you feel that it's being done very, very well here. You could be anywhere. You're here.
Yeah. No, I think I'm here because of the team and the people, and so wouldn't want to be anywhere else.
Dr. Mehaffey, thank you.
Of course.
Very good. Thank you. Thank you, Dr. Mehaffey, and thank you for joining us on this edition of The Heart of West Virginia. Very insightful discussion here. For more information, go to our website at wvumedicine.org/heart. For our producer, Chad Plochet Atkins, I'm Hoppy Kercheval, and thanks for joining us.